Welcome everyone to our Ontario Kinesiology Association hosted webinar today on dementia-inclusive choices for exercise. I'm Steve Fisher. I'm your Secretary Treasurer for the OKA, and very honored today to have with us Dr. Laura Middleton. Dr. Laura Middleton is an Associate Professor in the Department of Kinesiology and Health Sciences at the University of Waterloo, a research scientist at the Schlegel Research Institute for Aging, and an affiliate scientist at the Toronto Rehabilitation Institute, KITE. Laura's research aims to identify strategies to prevent dementia and promote well-being and independence among those living with dementia. She focuses on the influence of lifestyle, well-being, and independence among those living with dementia. Her research focuses specifically on the impact of exercise alone or in combination with other therapeutic approaches. And she integrates epidemiological, experimental, clinical trial, and qualitative approaches towards this aim. Her recent projects have used a participatory approach by involving people living with dementia, healthcare professionals, and community service providers as co-researchers to create accessible and effective solutions to support the well-being of people living with dementia in Canadian communities. So we're very excited to have Dr. Middleton today here with us to share some of the work that has culminated in the DICE program today. Just before we get started, a couple quick housekeeping items. Dr. Middleton will begin. She's going to share some of this work with us for about the next 45 minutes or so. If you have questions, I encourage you to please use the chat function to ask those questions. And at the end of the presentation, I'll take care of moderating the questions, and I can read those over to Dr. Middleton, and she can respond, and we can have a bit of a discussion. So without further ado, honored to have you today and look forward to your presentation, Laura.
Excellent. Thank you so much, Steve and Stuart, and for having me here today, and for all of you taking your lunch hour to attend. I'm going to talk about the rationale for the processes of and what is actually included in the Dementia Inclusive Choices for Exercise Toolkit and how that might be able to help you as kinesiologists. Importantly, I am just one of equal team member on our DICE team as part of a participatory action research project. The diverse perspectives of the DICE research team are considered in all phases of the project, including setting of project objectives, processes, knowledge translation, and evaluation. Our team includes researchers, 2 people living with dementia, a family care partner, exercise providers, including clinical exercise professionals and kinesiologists, dementia service providers, and healthcare providers. We purposely reflect on all of these experiences and perspectives with an aim to increase the relevance of our resources on our target groups. So first, I'll give you just a high level of our session and of our process. So with an aim to improve the well-being of people living with dementia through physical activity and exercise, we aligned our project processes with a CIHR knowledge to action cycle. You can see a simplified version on the top right. Basically, this is meant to identify a problem in the community and implement knowledge and evidence into action with an aim of resolving that barrier or that problem. So here we're addressing low levels of physical activity and a lack of understanding of dementia in our communities. So I'll first talk about this problem, the rationale for the DICE project, as well as the barriers to physical activity among people living with dementia. Next, I'll provide a brief overview of how we use participatory processes and co-design to create our DICE resources. And finally, I'll tell you about the tools that we developed and how they may be useful to you, as well as evidence for their effectiveness. Of note and perhaps relevance to you, I won't provide all the DICE training in this session, although we can always talk about a return, but I will talk mostly about how what's out there, the training modules we've created can be used and useful, as well as the additional resources. And just give you a brief preview of some of the key lessons or learnings from those modules. So first, let me start around the current status for people living with dementia, as outlined in Canada's recent National Dementia Strategy. In this strategy document, it outlines the current status in several areas, as well as what should be the goal or aspiration that we should be working towards. Right now, it takes years for many people to get a diagnosis of dementia. And once they do, they're given little support from the physician or the healthcare system. They may be given one of the 4 approved drugs for Alzheimer's disease, an acetylcholinesterase inhibitor or memantine. They'll likely be told to start planning for the end of their life when they may lose function and communication. They may have their driver's license taken away immediately. At best, what happens most often is they're referred to the Alzheimer's Society for care or counseling. And while each of these are important steps, it's not enough. It's not enough to support people living with dementia in their care, rehabilitation, counseling, and support. They should receive the same services and supports that we might give people with other diagnoses like cardiovascular disease or even a cancer diagnosis, where the approach is holistic. As a result, a goal of Canada's dementia strategy is to provide a timely diagnosis in a compassionate manner, and importantly, with immediate availability of resources and support. I admit that I like the words of Roger Marple along these lines. He is both a friend of mine and a person living with dementia who is a tireless advocate for change. To an audience of people living with dementia and family members, he said, "What if we started with hope? The learning process for dementia needs to include hope for living well and practical ways to achieve this. This should be taught first." And so what can we give people living with dementia to support them to live as well as they possibly can? While the answer would be slightly different depending on who you ask, I would say, and several of the clinical guidelines agree, that one of the key supports that we should provide is accessible, evidence-based exercise programs and opportunities for physical activity. And I would also argue that access to exercise and physical activity is a right enshrined by the UN Convention on the Rights of Persons with Disability. In that document, there is a right to equal access to habilitation and rehabilitation for all persons with disability, including people living with dementia. What is included in this mandate? Strategies to attain and maintain functional independence, physical, mental, and social ability, and full inclusion and participation. They say that measures to support habilitation and rehabilitation should be available early after diagnosis, close to their homes, and should support participation and inclusion in activities in their community. To ensure these supports are available, professionals working in these areas need to be trained to engage with and meet the needs of people with disability, including persons living with dementia. And so why should exercise be considered an essential part of habilitation and rehabilitation? Well, there's strong evidence that exercise has a broad range of benefits, particularly that it improves the functional abilities and independence of people living with dementia. And this comes from good clinical trial evidence. Now, the reason for these benefits are likely due to an array of benefits associated with exercise that are perhaps not surprising. Improvements in strength, in fitness, in balance and mobility, as well as improvements in cognitive abilities among people with dementia, as well as people without dementia. Now, further side benefit to people living with dementia being active is that their family care partners are also less likely to experience caring-related stress and burnout if the person living with dementia is active. But our experience has been that when you talk to the person living with dementia, they often talk about the social and mental benefits of exercise first. So the importance of these shouldn't be minimized, even though they're not the focus of clinical trials. When people living with dementia talk about physical activity and exercise, they often first mention the social engagement and support that they receive, the companionship and the sense of community within the exercise program and with their exercise provider. Their confidence and mental well-being can improve through gains made with exercise, and this confidence can carry over into their everyday life. Especially for those who are active in earlier life, ongoing participation in exercise and sports can help to maintain a sense of identity. And so what we know is that exercise has a wide range of benefits, but that people living with dementia are not sufficiently active. They're even less active than the general population. We also know that current dementia-specific exercise opportunities are not sufficient to meet the diverse needs and preferences of people living with dementia. And you can imagine that no one exercise program would be suitable for people from 50 to 90 years of age. And that's what we're seeing with people living with dementia. They can be younger and fit, they can already be active, or they can be quite frail. And so we need to open the number of opportunities that are available to people living with dementia. And so to better understand the barriers to inclusion of people living with dementia in exercise programs, we talk to a number of groups, both in urban locations, such as down here in Southern Ontario, as well as to urban and northern groups through our partner site at UNBC in Northern BC. And they talk to people both in Prince George as well as Kitimat. And so we had interviews and focus groups with people living with MCI and dementia, care partners, exercise providers, which included kinesiologists, as well as healthcare professionals. We structured our questions as well as the analysis by the social ecological model, which basically maps out barriers to health behaviors at the level of individual, social interaction, as well as community issues. And then to enable mapping this forward to what our intervention might be, we use the behavior change wheel. This is a framework where you map the barriers to a behavior, and then that helps you map them to the key interventions, which are in the second ring out. Here in black, I'll show you what was known from prior research, but also highlight in red some of our emergent findings. So the capability barriers are probably the best recognized. Of course, the cognitive and physical changes common with dementia or are often comorbid with dementia are barriers to exercise. That's often what people think about. But these levels on the individual are magnified by opportunity barriers. Some of these are common broadly. Poor access to transportation, poor weather or safety are of course barriers to being active. This is particularly the issue in northern or rural communities where snow is a greater issue. And what we found out is that bears are a real threat in these communities and restrict their participation. Availability of people with expertise and equipment can also be more of an issue in northern and rural communities. However, even where there is access, the lack of people, programs, and facilities that are dementia friendly, where people understand dementia and use ways to support their inclusion, is still limited. And this is even though we know that the supportive voices of exercise providers alongside of care partners can be key motivators to be active, along with the resonance of the activity as meaningful based on their own preferences and experiences. And so we combine these barriers at the level of the person living with dementia to some of the knowledge we gained from exercise providers. So when we talked to about 30 exercise providers to understand their experiences with dementia and perspectives. We found out that they have quite unique experiences across each individuals, and that these experiences inform their perspective on dementia. Sometimes the experiences can be positive, such as a loving relationship with a family member who is able to stay active for quite some time, or they can be quite negative if they've dealt with people living with dementia just in acute care settings where they may be feeling ill and upset. Because of these diverse experiences, alongside a lack of training, exercise providers were mostly forced to rely on learning as they go, rather than implementing best practices. And so from here, we thought there was a clear need for accessible training and education that provides a baseline best practice, recognizing that your practices in working with a client will always have to be flexible and adaptable to the individual. And so from the problem we had identified, we created a vision, and this was to increase the number and quality of physical activity opportunities available to people living with dementia by training the people providing exercise and physical activity programming in the communities so that they understood and could meet the needs of people living with dementia. From a behavior change perspective, this is termed enablement. We're not changing the people's ability or the physical opportunities, but we're changing the ability of the people to participate in those opportunities as they're available. And so as we came together to tackle this problem, we engaged a large group of stakeholders, mainly on two levels. First, we have the research team itself that I alluded to earlier. Here you can see photos of our team members, including people living with dementia, care partners, researchers, exercise providers, dementia service providers, and healthcare professionals. This research team provides strategic oversight for the project, integrating the input from all these team members alongside existing evidence to make decisions on the direction of the project. We meet monthly over Zoom, starting even before Zoom was as popular as it is now. And we make decisions on targeted questions through reflection and discussion within the research team. Now, to design the tool specifically, we brought together both the research team, but also additional stakeholders. So additional people living with dementia, care partners, clinical exercise physiologists and kinesiologists, as well as other community stakeholders in a focused workshop that would provide a framework for tool development. We confirmed and expanded the key knowledge that we wanted to be translated and how that knowledge would be packaged into tools. This included a series of individual, small group, and large group activities to focus in and prioritize for tool development. And this is where we ended at the end of the workshop, with 4 different prioritized tools. First, we have a multimedia training modules that include videos, text, and case studies to inform exercise professionals to understand the variability of people living with dementia, what are some useful strategies for their inclusion, as well as how to adapt both how you deliver exercise and the environment, and support uptake and adherence to exercise. We also have a series of motivational videos. And I will say, as I'll highlight later, that these were probably the most impactful when we talked to people after our pilot study. These are meant to understand, again, the variability of dementia, that people living with dementia are still people with diverse abilities, with different experiences, with families and friends, and who enjoy being engaged. We also wanted videos that showed how exercise can be fun, meaningful, and beneficial in dementia. And then how exercise professionals can support participation and progress through physical activity programs. We also added a passport to exercise, or what we've ended up calling a wallet card. And this is meant to help communicate your individual clients' abilities, preferences, and goals for physical activity to the kinesiologist or other exercise provider. It's a short form to just capture some of that unique information that might help you adapt your practice to them. And finally, the co-design participants really thought it important that information for people living with dementia and their family was also included in our toolkit, and that this should show the benefits of exercise, a variety of options for physical activity and exercise, and advice on getting started. And so following these co-design workshop output, we started the iterative design of our DICE toolkit. First, we met with the research team to come to consensus on our path forward. And then we worked with designers and the research team to create our tools. We made additional changes to the tools after usability testing amongst exercise providers and people living with dementia, and then conducted our pilot evaluation of the tools this past year to end up with the final versions that I'll preview with you today. And so all our tools are created and hosted on the DICE website. It's easily found at www.dementiaexercise.com. The training modules and associated resources that I will discuss in a little bit more detail momentarily can be found under the respective tabs for people living with dementia and their care partners, or for exercise providers, which is where most of you would look. The main resource that I would say is directed to kinesiologists is the DICE training. This training is done online under 5 separate lessons. The first focuses on understanding dementia and the diversity of people living with dementia in terms of age, the changes they experience, as well as retained abilities. This includes a review of the cognitive, physical, and sensory changes that people may experience with dementia, as well as a review of dementia types. We also include some signs that may suggest someone is experiencing cognitive impairment, whether it's dementia or not. We talk about the rights of people living with dementia to inclusion, particularly an exercise program, as I talked about earlier. Then we introduce core dementia inclusive principles that may be relevant across exercise practices, but also in other types of programming. This includes some strategies for dementia-friendly communications, thinking about the full continuity of supports needed for someone to get to and then participate in programs. The last 2 modules are really focused on physical activity and exercise. The first outlines the benefits of physical activity, their guidelines, and some advice for implementation. And the second discusses core principles for dementia-inclusive exercise, some key approaches, as well as a menu of supports that may be useful depending on your practice, as well as the needs of your specific clients. The DICE co-design team, as I mentioned earlier, thought that a multimedia format would be most suitable for a training module. So each lesson within the module includes videos, text, images, case studies, tips for practice, as well as quizzes at the end to test your knowledge. To provide a versatile and practical approach for learning, users can start, pause, and resume training to fit their needs, and they receive a certificate upon completion. There's also an accompanying manual that you can print out as a reference guide for all the content learned. This is just a sample screenshot of what the training module looks like. Here you can see the different content in the lesson, as well as options to move forward and move back and mark that section as complete. Along this side, you'll be able to track your progress through the lesson to see how much more is available to you. At the end of the 5 lessons, that's when you receive your DICE completion certificate, which optimistically for me, I've already started seeing in resumes in applications to jobs. Now, the videos, as I mentioned, that we were regarded as highly impactful, both for exercise providers as well as for people living with dementia. And we have 3 that are core to the DICE toolkit, as well as one other not listed here, but that we produced just because of the meaningful voices that came out from our interviews. And that's specifically advice for someone newly diagnosed with dementia that could be still helpful for you to share with your clients. Now, the videos can be found embedded in the training modules themselves, but are also accessible on their own, both within the DICE website as well as through our DICE YouTube channel. For your interest, I have just a shortened version of one of our DICE videos. So this is about half the total content from the video called "Staying Active Helps Me Live Well with Dementia." Again, you can access the full videos on our site.
I didn't think I could, use most of the equipment because I've never been an exercise person other than for walking, but I love it.
Some of the benefits that people living with dementia experience with exercise would be improved mood, improved independence, just the ability to feel better day to day.
I feel more energetic and I think I sleep better. And exercise is totally doing me good, 100%.
I had a lady who used a walker every day after our exercise program. She does not bring that walker with her anywhere. She doesn't need it in the house. She walks independently, and I can only imagine how much independence that has given her.
When you feel more confident, I think, just in exercise, I feel like that translates outside of the building as well. So hopefully they feel more confident in some other skills, maybe conversing with people, because it is in an environment where you need to connect with others. And then there's a group class, so there's other participants and other caregivers. So that's a really important aspect of that benefit, that they feel, I think, positive about their physical ability, but then also their ability to still interact with people around them.
So it's sort of like, oh gee, life isn't going to be as bad as I thought.
And so that video just showed a few of the people living with dementia, as well as exercise professionals who've been involved in our project, as well as some of those clips there are part of our Brain and Body program at the University of Waterloo, which is targeted to people living with dementia and their care partners. So just moving forward to our other resources, in addition to the training module for exercise providers, as well as the videos, we house a variety of resources that can be downloaded free from the DICE website. These resources, the resources specifically for exercise providers, including kinesiologists, can help you to learn more about exercise and dementia through research reviews or different dementia-friendly community documents. They may be helpful for you to use when working with clients or to share with your clients for their reference. There are also resources available to people living with dementia that help them learn about the benefits of physical activity, ways to be active, how to exercise at home, as well as how to communicate their needs. So each of these can be accessed directly by people living with dementia and their families, or for you to share with them. I will just review a couple of the key resources. It's Time to Get Active is one resource. It began as a booklet that was developed by a consensus panel out of the Ontario Brain Institute. I was part of the panel alongside another DICE team member. However, when the resource in its original format was shared with people living with dementia, it wasn't seen as very dementia friendly. As a result, we worked with the Ontario Brain Institute and our team to revise the format and the content in partnership. The resource includes the benefits of physical activity, advice on the time and types of physical activities to do, and strategies to get started, stay safe, and maintain participation. We also developed the Being Active at Home resource. At the beginning of the pandemic, as programs were shut down, it became clear that we needed some supports for people at home if they were going to stay active. So the Being Active at Home resource is a 4-page handout developed by the DICE team. And it includes, again, information on the physical activities that people living with dementia should do, as well as advice for planning an at-home physical activity plan, and strategies that may help support physical activity at home among people living with dementia. So we focused on supports that we thought care partners might be able to implement. This may be useful for you to share with your clients if they'll be doing part of their exercises at home. These are the DICE wallet cards or passports. They're small credit card sized pamphlets designed to fit in a wallet. It's meant to help people living with dementia to share key information with you. So you can see information about their goals, the types of activities they enjoy, as well as some supports that may be important to help them be active. And you can use this to communicate with your clients. We also house an array of additional resources on the DICE website that may be useful to you. We have a lengthier intake form that was specifically developed to engage people living with dementia in exercise. Now, instead of reinventing the wheel, we leverage this form from one developed by Late Life Training called Planning for I Can. So this is a group out of the UK that trains exercise providers. There are also some sample exercise videos and handouts that are suitable for people living with dementia. We include research reviews and additional resources to support dementia-friendly practices and environments. Now, again, I won't go through all the learnings from the DICE training and tools, but I thought I'd give you just a little teaser. On the left, you'll see our fundamental approach to inclusion of people living with dementia. And importantly, this kind of demands a person-centered approach. Even if you're in group exercise, you can just be aware of the person's unique abilities, because there's no one set of adaptations that are appropriate to every person living with dementia. Now, many of the key adaptations are not fundamental to exercise, are not fundamental to people living with dementia or to exercise, as the guidelines for people living with dementia in exercise are the same as for other older adults. Instead, the adaptations focus on your communication, delivery, and the exercise environment. Paying attention is always important for you as a kinesiologist, but even more so if you're working with a client with dementia. They may have more difficulty remembering exercises, monitoring their intensity, or communicating frustration or distress. To help them understand your instructions, use short literal phrases. Break down each step as an individual set of explanations if needed. Especially when a person has communication difficulties, nonverbal communication can be key. Both pay attention to their nonverbal communication and use it yourself. For example, nonverbal as well as verbal cues as you're moving through exercises. It's important to plan for an inclusive physical environment. A few items that can be helpful are clear signage so someone can find their way around the facility. Also consider the volume and the type of music. Loud beating music that's unfamiliar to them can be overwhelming and increase senses of frustration or distress, of anxiety. Try to reduce clutter where possible, although often in gyms this is difficult. Be aware of the placements of mats and mirrors. What's interesting is that these things can sometimes be misinterpreted by people living with dementia who have visual perceptual changes. For example, mats can be interpreted as holes in the floor and mirrors as another person. So just consider if that's an issue for your client. Now, it's important to recognize that the supports that a given client with dementia needs may vary according to the day, the time of day, and over time. So you'll always have to be patient and be adaptable to their needs on any given day. And I think one really important message is don't be afraid to encourage and challenge them. So many of the exercise programs available to people living with dementia are gentle exercise. But exercise is a place where they can often still experience success and improvements, and so gain confidence, which can then carry over to their everyday life. And so before I move on to questions, I'll just quickly go over the impact of the toolkit as assessed in our pilot study of the tools. Here, I'm going to focus on the results related to use by exercise providers, although we also evaluated the use amongst people living with dementia and care partners. So due to the COVID-19 pandemic, all evaluation had to occur online. Nonetheless, we were able to recruit 19 exercise providers to our pilot study, 16 of which completed the pilot. Certainly, the changing demands and the required change by exercise providers made it more challenging to engage with and keep our participants. Each person who participated had 6 to 8 weeks to review the DICE toolkit, though in practice, the training probably doesn't take more than 2 hours altogether. They recorded their reflections as they went through the training and as they tried to implement these learnings in practice. Of note, for some, implementing the learnings in practice was again challenging due to COVID-19. Some people had their practices shut down, and so they had to guess how they would implement the learnings as opposed to actually have the experience implementing them. So the effects of the toolkit were assessed both using quantitative measures as well as through qualitative interviews. Here we present changes in 3 scales: a self-efficacy scale for delivering exercise to people living with dementia, which was adapted from a teaching self-efficacy scale; the dementia attitude scale that captures apprehension of working with people with dementia, any fears they have about dementia and challenges, as well as the dementia knowledge assessment scale. Of note, the latter was added partway through to replace an older measure, so only 10 people completed this scale. The interviews probed their experience with people living with dementia, as well as experiences with the toolkit, what they learned and relevance to their practice, as well as changes that they would implement, and feedback that we could incorporate. We also probed strategies that we could use to connect people with dementia to trained exercise providers. And because of COVID-19 and the rapid change in practice, we also took the opportunity to ask about their practices in virtual delivery and how we could support them in our content. The latter 2 I won't touch on too much here. So here is a key summary of our participants. You can see that we had quite a range of ages and practices. About 1/3 of the people were kinesiologists or clinical exercise physiologists. but people's practice included clinics, in long-term care, in YMCA, the gym, or community senior centers. Of note, 2/3 of people were already working with people living with dementia, so represent a more experienced group than we might typically see amongst exercise providers and kinesiologists. Optimistically, all 3 scales showed improvements. That is self-efficacy for exercise delivery, attitudes towards dementia, and knowledge of dementia all increased after the use of the DICE toolkit. Now, if we break it down into groups of people who are currently working with people with MCI or dementia, mild cognitive impairment or dementia, and people without experience, there are some interesting differences. First, we can see that at baseline, the biggest difference was in attitudes towards dementia. Again, people without experience were more fearful of dementia and working with people. They had a little bit more stigma. But by the end of training, the attitudes towards dementia were similar between the 2 groups. Second, both groups saw improvements in self-efficacy for exercise delivery, but not surprisingly, the people without experience improved by about twice as much as those with experience. Finally, the baseline knowledge of dementia was actually not that different between groups. And surprisingly, it was the more experienced group that showed greater gains. Now, this information came from the interviews, just coming close to wrapping up here. When we talked about the materials, exercise providers broadly thought they were valuable tools to train exercise providers to understand and meet the needs of people living with dementia. Those with experience would use the tools for refreshing their skills and knowledge and for training others. One said, "One prime example in which this can be used is whenever I receive a student for placements. I feel as though if they were to complete the DICE modules, it will help give them a better understanding of not only what it's like to live with dementia, but also the relationship between exercise and dementia and how to implement exercise for those living with dementia. For those with no experience, they were able to gain valuable knowledge and overcome preconceptions and gain confidence to deliver exercise to people living with dementia." One said, "It was very informational, very educating, and I like that. Like every module was something new for me to learn. I think the videos were really well done. I think that gave me more insight to see what it was really like." And so that leads into this last one, where we found that the videos were really key for changing perspectives about dementia. A couple examples are, "I love the videos. It kind of made you stop and think about when you see the person living with dementia in the videos, explaining how they feel." The one gentleman about his partner, "Yes, the videos were excellent." Another said, "What I enjoyed was the videos and testimonials that were given by people living with dementia. I found that the videos were very engaging and very well put together. It was nice to hear directly from individuals living with dementia, but also how exercise directly affects their everyday life." And this is in line with other evidence that we know, where seeing and engaging with people living with dementia is really fundamental to changing and reducing stigma of the condition. There were a few areas that we can still improve, including more information about applying principles to group exercise. And we added some additional guidance and case studies, as well as guidance for virtual delivery. We did add a case study here, but we also may add additional content as the best practices continue to develop from internal and external research. There was also a desire for guidance in long-term care. This was outside of the scope of our practice that was really focused on community exercise, but we see this as perhaps a next step or opportunity. So just in conclusion, and I see Steve there online, we did use a participatory process in this project that we hope created resources that meaningfully address issues related to physical activity and dementia, both from the perspective of people delivering exercise as well as the people living with dementia themselves. The DICE toolkit was well received and considered beneficial to exercise providers. They indicated they would use it in their own learning to refresh their knowledge or to train others. And importantly, not mentioned yet, the DICE training is available and free to you on our website. So it is easily accessed by all. So I'd just like to thank you all for taking time out of your lunch hour to come see this, as well as, of course, to our broad DICE project team and our community partner organizations and funding. So thank you very much. And I will just stop the share so I can answer questions.
Laura, thank you so much for taking some time to share your efforts and the efforts of your broad DICE team. I think these are remarkable resources to help us as exercise practitioners support those living with dementia, particularly through exercise. We've had a few questions come in through the chat, and I'll just share them with you now. The first one is around statistics. Can you give us some perspective on the current stats regarding people living with dementia in Canada?
Absolutely. So what we know from the recent National Dementia Strategy report is that there is nearly 500,000 people in dementia in Canada living with dementia. There's probably at least another 100,000 people who are living with dementia but not diagnosed. Because of the projections largely around the changing demographics, so more older adults, that's expected to exceed 1 million people by 2030.
Wow.
Yeah.
Some follow-up questions related to content that's available. So a couple related questions. One, are your slides available within the 5-part certification? And the second is the forms, kind of the 6-page booklet from the Brain Institute and DICE. Are those available in the modules as well?
Yeah, so right now I don't have slides, although I know, Steve, that's something that we've talked about, is making kind of some training slides available broadly too that other people could use in presentations. So these ones I'm happy to share with people as a PDF for one. And I'm also check back with me on development. I mean, any questions around it is just a stimulus for me to get on top of developing that kind of standard slide deck that people could use.
Great.
And certainly the OBI handout is available online.
Great.
To download. Yeah.
And just for those of you that are enjoying the webinar today, we will, with Laura's permission, host this on the Keen portion of the OK website, so you can access this in the future if necessary. Another question from one of our audience members really, I think, mentions the kudos for the resources in the webinar today, but wondered if there's a directory for those that complete the training. Is there a live directory of those folks that have completed the training, such that, that there's a mechanism to kind of reach out and refer and this type of idea?
Yeah, and we know that that is the next step that's needed. The Alzheimer's Society has expressed interest in hosting that directory. So because we're early on, we have the list that's building up, and the plan is to share that with the Alzheimer's Society. Although we're also exploring other ways to connect people living with dementia with trained providers. If you have insights on, as a kinesiologist, how you'd like that to be done, I am happy to hear from you, because it could be something that we could host as well. But we just want to make sure it's posted in places where there's obvious access. So happy to hear from you if that's something you're interested in and you have some ideas of how you'd like that to be structured.
Excellent. Just a kind of a tag along on that, more for the audience members that are attending. Hopefully many of you know that OK has partnered with Health Locator as a sort of a search engine find a kin repository. So maybe there's an opportunity to use your Health Locator profile to share that you have that DICE training as well for the member that asked the question.
Awesome.
A question came in around funding for the program. So within a private clinic, if they offer the DICE kind of the DICE formatted programs and exercise classes related, do you know if there's pockets of funding available to make these programs accessible, or are clients paying out of pocket? What does if I can ask, what does the business model around this look like?
Yeah, so there's not specific funding for people living with dementia, although they can be, included in the same way as other services would be at this point. One, they're likely to have comorbid conditions that make them eligible for services. Many people, I know what we've done at University of Waterloo is, billing under private healthcare insurance where that's possible. Certainly, something that needs to be done, and a major goal of dementia advocacy organizations is to have, rehabilitation and habilitation practices, which I think kinesiologists would be a core group to deliver those, to make that actually accessible and funded under healthcare models. But sadly, because of all the weaknesses, outlined at the very start in terms of our care of people with dementia, there's not specific funding to that group yet available. But I'm happy to explore that.
Great. We have a few more minutes left. If there's any other questions, feel free to sort of type them in the chat. Laura, can you give us a bit of a sense? So when did DICE launch, and sort of what are you seeing in terms of uptake for professionals completing the training?
Oh, that's a good question. So there was kind of the soft launch in that we've been piloting it over the last year, but the formal launch was only a year ago, or a month ago, I should say. So I should go on to those stats and see the uptake. Optimistically, we've had reach, and people contacted us from, Australia, the US, the UK around uptake. And certainly I get some emails around the uptake numbers, but I would have to check back on that, Steve. I'm not sure where our numbers are at a month in.
Any other questions from the audience while we have Dr. Middleton with us? Again, feel free to type them in the chat. Just while we're waiting for any additional questions, Laura, any thoughts? I know you mentioned a few little nuggets about future directions for the DICE program and opportunities, but anything maybe that you can give us a heads up on, of things to watch out for in the future, or to keep an eye on?
Yeah, I mean, a couple things that I think of are directly related is we recently received funding from the Public Health Agency to also essentially expand our DICE training and resources to also include more content more broadly about physical activity, but also to add healthy eating resources to our training and resources. So if that's of interest to you, if you, as kinesiology, it's quite common to also provide advice around nutrition and eating. So if that's of interest to you, we will have resources that are available soon for that as well. We've also been developing a program, targeted, that could be offered in different locations if you want a pre-packaged program that is that we're just starting to evaluate. That's called the Delight program, and the core of it is exercise, but also, similar to a cardiac rehab model, has an education facilitated social session as well added onto it. So we have, probably 30 to 50 resources that go along with that program that you could offer alongside exercise if that's of interest.
Fantastic. One other quick question here. From a research perspective, during the pilot study, were there any participants with early onset dementia? And if so, was there a noticeable difference between noticeable difference in those folks as a function of the effects of physical activity versus just a kind of an older adult population?
Yeah, So certainly there were participants with early onset dementia in our participant group and also on our research team and in the co-design. So in both of those, we had people with early onset and late onset. From our perspective, as you suggest, there's are very distinct needs between those groups. I think one of the biggest challenges for people with early onset is that typical dementia programming is really geared towards the late onset group. So if you're 50 years old when you're diagnosed with dementia, you're often healthier physically, you're more active. And so those programs often don't meet their needs. And so that's really one of the things that drove us to develop the DICE training, so that they could go to a program that's more suitable for them physically, and hopefully still participate because the person delivering it understands their needs.
Great. So with that, I think we've come to a close in terms of our time here. Laura, we've had a number of comments being shared in the chat.
Yeah.
And thank you and congratulating you for all of your efforts and the work of the team. So happy to have you here today, sharing a little bit of the extensive amount of work that you've done for the Dementia Inclusive Choices for Exercise program. So with that, on behalf of the OKA, Laura, thank you very much for taking some time today. And for the members on the call, Laura and her team have also helped extensively contribute to the BPG best practice guideline information that's available in Keen as well. So Laura, thank you so much for your time and effort and support of those living with dementia.
No problem. Thank you all. Thank you, Steve and Stuart, again for hosting me, and for all of the participants for taking the time out of their day to come and learn a little bit more, because that's really what our goal is in the end, is to put this into practice. So that's about talking to everyone who's on the call and is motivated to improve their practices and the ability of people living with dementia to participate.
Great. And hopefully everyone can tell all their kinesiologist colleagues about the DICE program and opportunities for training as well. So we're all prepared to work with clients living with dementia.
Yeah.
Again,
Well,
thank you.
Can I add one thing, Steve? Because I thought about this when it was offered earlier. I think it's important to recognize that some of the adaptation, there's so many conditions that the kinesiologists would work with that have people with cognitive impairment, but just are not defined that way. Stroke, Parkinson's disease, even cardiovascular disease, just generally heart attacks, it's common, multiple sclerosis, all of these conditions have very common cognitive impairment alongside. So these practices are really generalizable to all those groups as well, just accommodating the cognitive changes alongside the physical ones.
Which is great. And I think so important as we think about, like you said, the changing demographic that we're facing and the needs that those folks will have, particularly around exercise moving forward. So again, thank you so much. Thank you to everyone that was able to join us today, and hope you enjoy the rest of your afternoon. Thanks, everyone.
Thank you.